Thank you very much, Chairperson, for that kind words of introduction. I was impressed by the resume, which, all the PhDs and all that, and thank you anyway. So let me first of all thank Diabetes India and the DASG for inviting me today, and a very interesting and a challenging topic, and a topic of the Ahmedabad Declaration as well. So young onset type 2 diabetes. In this, pathophysiology or the etiology, all these factors we'll try to quickly go through: the beta cell dysfunction, the lifestyle factors, the genetics, pollutants, and the in utero exposure to diabetes, so on and so forth. It's a problem in our part of the world, but worldwide you can see the numbers are staggering, and a problem in other parts of the world as well. Let me start with our very young registry that we just started a couple of years back. We have about 3,000 to 3,500 patients registered so far, but this is less than 25 because of the staggering numbers. It's a cloud-based, multi-center throughout the island registry that we started for young diabetes. We have analyzed the first 2,500 or so patients, and these are the statistics we got. Majority were type 1, and about 35% were type 2, young onset, less than 25, mind you, not the 40 usual cutoff. And the other types of diabetes was about 8%. This is compared to a recent Indian study where they had 40% each, but this is less than 40 years. That's the difference in the Indian study. So it was like type 1 and type 2 equal, and a higher number of pancreatic diabetes is noted in India, which was not the case. Only one case was there out of 2,500 patients in our study. And, genetic diabetes is about 3% in your cohort. So in our cohort of this 8% of other types of diabetes, and the patients who are in my personal clinic at the National Hospital in Sri Lanka, 53 patients I analyzed for these 13 genes of MODY just to see how things are. This is not a prevalence study, but to look at the etiology of the others. And out of the 51, but there is a selection bias here, and out of the 51, about 24 were positive for one of those some of the genes that I have shown here, the 13, with the highest prevalence of 31% for MODY3 in our cohort of less than 25 young diabetes cohort. And of course, they had varying levels of mainly microvascular complications, not much of macrovascular complications, and the vast majority were on insulin. And some of them, the MODY tested ones, we were able to get them back on oral hypoglycemic agents after the testing because they were as treated as some as type 1 diabetes. And the characteristic population data, strong family history in most of the young people, and the HbA1c is uniformly more than 8.5 in the majority, with the complication rates showing nearly around anything between 5 to 10%, and dyslipidemia was the highest comorbidity associated in about 15% of the patient. So when you look at the world data, we notice that our percentage of type 2 in that group was higher in the less than 25 group, and the 57% of patients age 18 years or above were obese, and 73% of the younger 5 to 18 group were obese in our cohort. So you all know the problems, so the challenges for the future also can be identified, and poor glycemic control and investigation. A study done by the Diabetes Association in Sri Lanka 10 years back, along with King's College London, had a glimpse of what would be the prevalence in Sri Lanka at least, and I think it's comparable with the Indian data, although it's a bit old. Here, 20,000 patients, 5 to 40 years. I'll just concentrate on the dysglycemia only. The risk factors prevalence is given there. It's about 8.2%. And more than 20 years, 22%. And our national average done recently came as 23% for diabetes in adults in all over the country. These are more relevant, more recent meta-analysis done by some of your colleagues, looking at the pediatric obesity rate in South Asians, 5 to 19 years. Very recent publication. About 206 million have been identified. Within India, it's about 6.5% obesity, Sri Lanka 4.8, and the average is also about 6.6 with a overweight and obesity prevalence of about 20%. So you know the challenges. Obesity, childhood obesity is going to be a key challenge for us with youth onset type 2 diabetes, and the urban-rural divide. You know, the prevalence is about double, 24%, 21% versus 10.2 in urban versus rural in all these studies in all parts of Asia. That's been noted. That has been shown in many studies, and the challenges ahead for us. And this was, I think, this article by Dr. Mohan and his Kelly West Award lecture, which we listened to recently at the ADA, summarizes all the problems associated with the problem of youth onset type 2 diabetes, especially the South Asian phenotype that we are talking. He looked at South Asians in different countries from Fiji to Canada, and they all came up higher in the prevalence rates were higher compared to other ethnicities. And here, what's peculiar about young onset diabetes, it occurs especially in the South Asians at a lower BMI, younger age, high risk of unfavorable fat distribution. I think this has been repeated many times, the liver fat and the pancreatic fat, and high genetic risk of insulin deficiency, initial insulin resistance, but they quickly go in for insulin deficiency, poor response to oral hypoglycemic agents, and rapid progression to microvascular complications. So this is the challenge that we have in our region. So the ALPIS, you all know, ALPIS came out with this classification for etiopathogenic classification for diabetes, knowing with the genetic the understanding of the genetics and the antibody status of diabetes. Severe insulin deficient diabetes in South Asians is supposed to be more common. And in this article, he summarizes nicely what happens, the life cycle of what's happening from preconception to conception, GDM, overweight and obesity in adolescents, leading to low birth weight or high birth weight, which all amounts to increased fat, and overfeeding later causes excess fat or adiposity, or the thin fat Indian, or what we call the fat overflow hypothesis, and the increased liver and pancreatic fat, and hyperinsulinemia. Mind you, even now IDF president said that it's 1/5 of the type 2 diabetes is caused by air pollution. And there's a lot of evidence now that air pollution can increase the insulin resistance in many ways. And all this leads to what you call as young age onset with a lower BMI type 2 diabetes in our part of the world. In this study, it's very interesting. The wheel has gone the full round. Earlier, we used to say data South Asians, especially Indians who migrate to Western countries, show the increased prevalence of diabetes. And now, in this study by, again, Dr. Mohan shows that in Chennai, in the city, the prevalence of diabetes is much more than similar South Indians or Indians living in San Francisco and Chicago. So it's the changing lifestyles, not the genes, that has caused this change, as shown in many other studies. And again, he shows that in India also the rural, the city, the urban divide is shown there in the prevalence of type 2 diabetes. And the lower frame, the B there, shows the onset of diabetes is about a decade earlier for the Southeast Asians, compared to especially the white Europeans. And also the prevalence of the peak prevalence also comes about a decade earlier for Southeast Asians. So what's happening here and what are the challenges? So the subtypes in diabetes, this is not accepted all over, but it fits well with this problem, the etiopathogenesis. So there are studies to show that insulin resistant, severe insulin resistance and combined insulin resistant and deficient diabetes is more common in our part of the world, 40% versus 17.5% in a Scandinavian study compared to the European. So these are all interesting new things and concepts that we have to think of. And this was done in Scotland, east of Scotland, where the Indians living there was compared with the natives, and it clearly shows this hypothesis that the same BMI, you can see the prevalence rates of diabetes was much higher. C-peptide levels were much lower in the South Asians and lower genetically determined beta cell function. So that's interesting. There are lots of papers coming about this genetically determined beta cell function and why we are having a so-called the thrifty gene or the genes. People are zeroing in on these genes. So these are very recent Nature Medicine paper done in UK in Indians living there, and they have compared with the white Caucasians, and they showed a higher rate of diabetes, which we say anyway over and over again. But this is interesting. The partition polygenic score, that they are a way of looking at the contribution of certain genes for the pathogenesis. It's coming up this beta cell that is the insulin reserve of the beta cell. So basically low levels of insulin, lipodystrophy, differential distribution of fat. This gene controls more deposition of fat in the liver and the pancreas compared to the other areas, and the obesity related genes are coming up on this score as contributory factors for this young onset type 2 diabetes, mainly seen in Southeast Asians. And of course, they have looked at their response to oral medications. Metformin, DPP-4 inhibitors, SGLT2 inhibitors, all that is showing that they go in for OHA failure early in people, those who have these three genes, which was mentioned before. It's sort of statistically significant value. So you can see that our young people, they quickly need the insulin, and out of this, sulfonylureas, although temporary, may show a better actually a response compared to the other medications in this cohort of patients. So things aren't the same even in East Asia, so I didn't take a lot of data in the interest of time from that region, but it's not that as staggering as Southeast Asia, but it's a problem in East Asians as well, as shown in this study from Hong Kong. So what are the problems? Biological factors, lifestyle factors, urbanization, immigration, all that. How do we tackle this? That's the most important thing as a region and a country. So we know the pathophysiology, but not the genes for sure. But look at the suggested, risk factors. Some are easily modifiable. If you may see low B12 levels, low vitamin D, and in another paper it was the high folate levels. We sometimes overtreat, pre-pregnancy. That also can have effect, and fatty liver has been discussed, and primordial prevention, I would say, could address some of these risk factors which has increased the risk of youth onset type 2 diabetes in our region, and many other factors. Individualized treatment for your patients. They might have some of these rarer forms. Pancreatic diabetes, in that cohort you all had 15% in India. In our study it was like 0.001, very minimal. So that should be looked into. So it's like 80-20 when you look at the breakdown when it comes to type 2 diabetes, and MODY, LADA, and atypical diabetes, genetic diabetes, all that could be mixed or misdiagnosed also in this group. And we can't do anything about our genes, But certainly lifestyle factors and, if you attend to them, epigenetics can be altered, especially environmentally induced epigenetic changes and the lifestyle related epigenetic changes, mainly maternal hyperglycemia. If that is attended to, these epigenetic changes can be altered in a better way so that you don't go up the pyramid and end up with type 2 diabetes. And stress, pollutants, smoking, alcohol could be easily addressed by all of us in our countries. I think this is one of the most important slides in my lecture. I would say that, if you work on primordial prevention, preconception counseling, weight reduction, avoiding dysglycemia in pregnancy, pre-GDM or early GDM, EGDM study has there. Don't wait for 24 to 28 weeks. In high-risk people, better to check them even at the booking visit, or less than 20 weeks of gestation, you should check them. And then data is to show the Harper study, you remember, continuing risk increase in the neonate in all parameters with rising maternal hyperglycemia. And the follow-up studies clearly shows that higher levels of glucose, exposure to glucose in utero is associated with childhood insulin resistance and other metabolic problems in future. So what do we do? If you can, population approach will be the way forward for India and Southeast Asia. If you can reduce 10% of the carbohydrate intake in our people's diet, I think we can make a huge difference. And Peter was, IDF president was going on about frying the carbs and the fatty liver. So if you could reduce the cooking method, or India can come up with a, cheap air fryer for the region. I mean, at least part of the population, the way we cook, if that is changed, the population approach, a huge difference can be made, impact on the fatty liver and the onset of youth onset diabetes. So it's a life circle theory that we are talking about. And looking through the topic, I went through our Diabetes Association database, looking for some slides, and I saw that this Kathmandu Declaration, most of us wouldn't have been there at that time, the seniors would know, by the IDF, they came up with the same solutions, the life cycle solution for young diabetes. I think preconception or primordial and primary prevention would be the way forward. And I'm happy that we have the Ahmedabad Declaration, which has addressed most of these issues, and hopefully we can get together and make a change. Few things on advocacy from Sri Lanka I would like to share with you. If you could try the traffic light system, this labeling of sugary drinks and products with red, amber and green has made a big, at least a reasonable impact on people choosing them, and the manufacturers actually who are red has reduced their sugar content in their drinks to amber. So that's, population-wide approach. And now Diabetes Association, this is not by law, but, people who are volunteering in the sugar sachets, we put sugar is addictive and causes diabetes, like in the cigarette packet. So maybe we haven't done a study to check the effectiveness, but it works. Sugar taxes we promoted in 2017 for sugary drinks, a small tax depending on the sugar level. And these are the things, other things, and innovative ways for screening. Diabetes Compass, I'm the project lead for this. We are trying out an app, offline app, looking for high-risk people in the community and guiding them to the nearest hospital visit free of charge, which is there in Sri Lanka, to get their sugars tested. And with the twin cycle theory of Roy Taylor and the remission of diabetes, I would say newly diagnosed young type 2, we should all strive for remission, which could be done with a very low calorie diet, managed in the primary care setting with not much expertise needed. I would get you to read the direct study where the diabetes nurses did the job, not the doctors, and they reverse in about 46% of the patients at the end of 1 year. So it's a very good way to go. And we have developed in Sri Lanka a carb counter app. This is mainly for the type 1 initially, but it's very useful for type 2 and even for people at risk. We have given the photographs. Some of the Indian foods are also there, and they could get an idea about the load of carbohydrates in their diet. So, ladies and gentlemen, few last two slides: population interventions, holistic care, and multidisciplinary treatment. Starting from the family, inculcating good lifestyle in children and good diet in the family. If the father gets diabetes, children also should. It's just a balanced, healthy diet that we are recommending, nothing special. This part of the world, sometimes we see people have a special diet for the person living with diabetes and another diet for the family. That should not be the case. And we have taken this teacher-child-parent approach. In Sri Lanka, we have tried this. It has worked very well, where we get the nursery children in the form of a cartoon with a thin and a fat bird and, giving them lifestyle advice on diet and exercise, and they have taken the message to their parents. And after all that, we need the holistic care, as was mentioned by previous speakers as well, in managing our young type 2 diabetics to prevent them from getting many complications of diabetes and leading a happy life with diabetes. Thank you very much.